to the God question. I want to go to the God question because you didn't talk about it now. And I was intrigued with your finding that Islamic schooling is actually helping adherence. So people were, whereas if you work, and I worked a lot in countries which were predominantly Catholic or reborn Christians, and their religion seems to get in our way of getting people into care. Now you said it might be just due to schooling. And I'd like to challenge that and say, well, probably it's more of a social network, social support, which is much more important than the schooling issue which you got out now. And it doesn't have anything to do with God.
I'd like to come back to social support because I find that that's a word that means different things in different places in Africa. And for those of you who didn't read this with the same level of detail as my jury members, the education paper also dealt with Quranic education, and I left those results out for time, but there appeared to be an independent effect of Quranic education in terms of adherence early on in therapy. And this effect washes out later. It's no longer, it's not a durable effect. I think that what that really comes down to is the structure of the day, that the individuals who have had Quranic education, and the average in our group was 5.5 years of Quranic education, they are also, as part of that, adopting a lifestyle. For those who are praying 5 times a day at structured times, it's, I think, easier for them to take their antiretrovirals twice a day, as was necessary in the time period of our work. People had twice-a-day regimens. And we routinely counseled people on different options for how they can remember their medicines. And one of those options that we suggested, on the basis of feedback from our own patients, was timing it with prayer, particularly the morning and evening prayer. That worked out well. And I think giving people something to hang their medicine on right away is why we had this benefit in the early phase. And then if you look at those people who stay in care, we don't see that benefit persisting because everybody else finds some way. And so then they've got their way. But the people who were praying on a regular basis through the day, they knew what they were doing when they were doing it. I had one older man who kept his antiretrovirals in a small box, which he rolled up in the middle of his prayer rug. So every time, he would roll out his mat, take his medicine, and pray. And I thought that was
Hello, Jean-Pierre. You hear us?
Ja. Ja, ik hoor u. Heb je mee gebeld?
Can we move to Jean-Pierre maybe also for a few questions?
Yes, we will, yes.
This is Svi Berneman. I am the chairman of the jury of Kevin Peterson's defense. It's going on now. Are you ready to ask the questions to Kevin?
Maar die defense is toch morgen?
Hij denkt dat het morgen is.
No, it's today. It's going on right now.
Is it Jean-Pierre?
Ja.
Okay, if you prefer, I can ask the questions on your behalf. I have gotten your questions on. Okay? Or is there anything you want to say or you want to ask?
Let's drop it.
Okay, we go back to Professor Callens.
Okay, and I think structure might be one thing of it, but I also think that or don't you think that the construct and the belief of the disease is also important in how different religions view and act upon HIV? And I'm wondering in the Gambia, which is a mostly Islamic state, then how is it talked about? Is it as stigmatized as in a Catholic country? Is it hidden, or do they have some support from the imams?
Stigma was extreme. Denial was common, particularly in the beginning. But people had been conditioned to see it as a death sentence, and people who would otherwise perhaps have died at home were brought to the hospital and abandoned by family to die there because they didn't want those people dying at home. The social punishment that people experienced in the pre-antiretroviral era, which I partly experienced in the Gambia, was one of the more disturbing aspects of the care. So the stigma was high, specifically with the question of people's philosophy or spiritual views, their religion, and how that relates to the way they deal with the disease. I think that it's very important, but not easily cut down Christian-Muslim lines. So, for example, what I found was that among both fundamentalist Christians and fundamentalist Muslims, there were individuals who were ready to say, this is God's punishment. There are also those who are ready to say, this is God's lesson. This is God's challenge. And others who said, and I obviously have a lot of Muslim patients, who were ready to move on past the fact that they had the infection to how to deal with it. And that submission was I think, for those people also partly a religious declaration to submit to the will of Allah, if you will, without necessarily thinking that the big guy's got it in for you.
Okay, well, let's not go on in the religion too much if we might cause some controversy. But
and it's not my area of training.
yeah. So I'd like to ask a question about the paper on raltegravir. It struck me that many of the patients actually had a therapy which included PIs and integrase inhibitor and the NRTIs. And so I was wondering, now you did a case series, but could you have done a case control study, for example? Wouldn't it?
5 people?
Yeah, even with 5 people.
I would not do that. I would look at what we know from in vitro work on these individuals and the resistance testing that we have, and for those that didn't have specific predicted mutations but had a history of exposure to certain antiretrovirals, I would take that into account and think, what's the best I can do for this person now? And knowing that the resistance threshold for raltegravir, that is the barrier for raltegravir to develop resistance, the virus to develop resistance to raltegravir, is very low. I consider that a strong but brittle element in my regimen. And the reason I think there was so much failure on raltegravir regimens documented by others in the literature is that there wasn't anything to protect it. And so you had a good medicine which snaps like a dry branch, and then you've got nothing. And what sets our work apart, what allows our patients to have succeeded, is that, particularly in combination with darunavir for most of them, they had enough cushion around the raltegravir to enjoy its strength without exposing it unnecessarily to the development of resistance mutations. I think starting with naive patients, I think a randomized trial would be excellent. Raltegravir in place of lopinavir or darunavir, I think that would be an excellent place to
Without a
start.
PI then? Or with
Right, raltegravir without a PI in first-line therapy. But in treatment experienced people, these people had 5, 8, 12 years of exposure to antiretrovirals. I'm not expecting much from their nucleosides, and I just don't have many tools. It's either this works or nothing's going to work for them.
And then on the IRIS paper, unfortunately you didn't uncover the holy grail of IRIS, although you made a very good effort, I think. And I was wondering, I didn't read it within the paper, but wouldn't one of the reasons that you didn't find a big difference between the two, the IRIS and the non-IRIS group, is maybe not that those that are latently affected with TB, which indeed we have very difficult in discovering, but also because everybody is exposed to many pathogens without becoming overtly infected or are sick, but they're exposed to parasites, they're exposed to fungal diseases, they're exposed to other bacteria, which then gives a high background of immune activation, and thus you don't find a difference in both groups.
I think that that is an important observation for the prognosis of an HIV infection in sub-Saharan Africa. The head of our lab, Ramu, used to describe it as a sticky serum. She'd done some of her training in the US and lived and worked, done most of her work in the Gambia. And you can tell by pouring the blood that it's different. There's so many more antibodies and factors. So I think that the immune activation story is an important one. I feel that this study probably, even if the theory behind it was right, it probably was doomed to fail because the exponential expansion of an immune response means you have a very small lead time between picking up the soluble factors, interleukins and such, and then seeing that and getting your sample off to the lab and getting the result back before the person declares themselves with their illness. So I think that it was just optimistic to have baseline tests at wide intervals and hope to pick up a hint of something about to happen. Because when these things happen, they happen in shorter order than their intervals.
Yeah, plus not every exposure has to lead to overt infection also, so you just...
We could have had a lot of noise.
You could have had a lot of noise in it, indeed. And then I like the papers on depression and PTSD, because indeed mental health services in Africa are appalling. I was in the Eastern Congo recently talking to so-called psychologists, which do the best they can, but if you look at what they're doing, then it's really it's a bit very limited of the things they can do. But what struck me in your papers is you seem to prefer the causal relationship of depression and then low CD4s, but you don't explore a lot of because they have depressions, they don't come to the clinic and thus they have CD4s, the other way around.
I think that's sort of more obvious. So I wanted to flag some of that psychoneuroimmunology to say we may have to think more broadly about this. But indeed, the more straightforward explanations, sick people get depressed, depressed people don't take the initiative to get self-care. These are dominant.
Yeah. And which then goes a bit to the healthcare system that was made for the HIV patients, which is a heavy top-down system. It's really heavily located in the healthcare system. I didn't read a lot about how the community is involved in HIV care. People are have to travel to your clinic. You reimburse them for the travel costs, etc.
Some people have to travel 2 days to get to our clinic. Yeah.
So, wouldn't you try to get it the other way around and get the clinic to the people in the community? Or
I argue in the paper on reducing mortality that spreading access is key. In the early days of the epidemic in the U.S., we had evidence that showed that people do better if they have a specialist, expert HIV physician, and I think that that's true. And I enjoyed counting myself among their ranks for some years before going to Africa. But where you're dealing with where the challenge is getting people to access care and stay in care, and the choice of regimen is done by protocol. There's less clinical judgment needed, and what's really needed is to get more people more care more easily. Then I think, indeed, you need to lower the barrier. You need to spread out to multiple sites. And I'm not saying lower standards. I'm in favor of high standards. But I think look for the right balance between accessibility and professionalism.
do you still need a doctor to give the antiretroviral?
No.
Somebody.
I don't want to talk myself out of the job, but I think that I have several complicated things I'd like to say. But avoiding complications, it's probably worthwhile to have a physician closely involved with one's care during the first few months, in particular if one has a low CD4 count or active opportunistic infections, significant opportunistic infections at the time of starting therapy. I think that there's a white coat benefit of being involved early on and addressing the patient one-on-one and talking about the importance of adherence, just in the same way that talking to patients about the importance of stopping smoking reduces smoking rates. If you get a bully pulpit, I think you should use it.
And then lastly, when you had a 10-point questionnaire for depression, which then you reduced to 5, and now you were saying 1, but maybe 2. But maybe we shouldn't use any because we still have a clinical judgment in
Yes, my goal is to I think that when you're looking at provision of quality care, one of the ways to ensure that is to have a system, to have protocols which are followed, and to have those protocols alert people so that things don't get forgotten or slipped over. You know, just because my patient has this problem today, it doesn't mean I can ignore certain key messages in their counseling or their preventive care. Protocols allow us to continue to practice our art, but sort of fill in the potential gaps that might get skipped over. I lost track of where we were going with the question.
No, well, if you systemize too much, if you use too many questionnaires, we have questionnaires on depression, we have to look at scores for cholesterol, we have to talk about smoking, we have to talk about we have to talk about condom use, we have to, and you kind of systematically go through the things, but sometimes I feel that we lose track of the patient sitting in front of us, and we standardize too much. We have individualized care here in Europe, and we have public health approach there in Africa.
I agree. I'm in that boat, but I am, and I'm not at all. You've identified yourself as a voorstander of the idea of a clinician practicing the art of medicine. So let me preface what I'm saying by saying I'm not talking about you at all. I have some mistrust about the intuition, because there's room for self-deception, and this leads one potentially to making a diagnosis and ignoring other information. And if you throw in a few short questionnaires administered by ancillary staff, I think this just helps avoid, it gets more information into the picture, and it helps avoid things being sent off because that didn't yet fit the picture I'm painting of the patient I'm working with.
No, I agree. In my clinic, I always say the nurses are the best, the doctor is the worst, because he makes the worst decision and he doesn't follow protocol usually, but the nurses do, and so I like nurses more. Now I had one more question, but I seem to have forgotten it, so I will leave it at that. Thank you. It was a nice discussion.
Thank you very much. I will ask you another question that Professor Van Geertwerk has prepared. And you may want to take the book because he's referring to, but I'm not sure the pages correspond to the pages of the. So he says regarding page 7, so it's early in the book, where you.
We're going to go through.
Well, you put the questions. You know, I didn't have the time to just figure out where it's in the new version. So you would have said that HIV evolution is slower in Africans. He thought that Africans live 2 years shorter, most probably due to more concomitant infection that stimulates CD4 positive T cells. Do you have a comment regarding that? So, according to what he read in
I'm looking at that. And I'm going to quickly look at the article that I cited when I said that. I'd like to take a pass on that question, thank you. I'm not. I cite that in my introduction because I was convinced by the article at the time that I read it, and looking now at the author and the title, I can't remember the article, so I'll have to defend that article to Professor Geertwerk out of this.
Yeah, so it's not your work, and so it is nothing.
It's not my work. I'm not particularly.
Not your conclusion. Okay. Then he says a little bit further, 6 pages further, ART coverage is 11 to 31% in Europe. Maybe it's in the original version. So page 13.
Yes.
ART coverage is 11 to 31% in Europe, Asia, Middle East, question mark. Explain why this is so low. Sounds similar as sub-Saharan African imitators?
I think that different regions, different populations have different risk factors, and if you were, for example, an injectable drug user in Eastern Europe, it may be that you have, in theory, better access to antiretrovirals than the third wife of an older sexually experienced man in a rural village in West Africa. Nonetheless, there are other barriers that may present themselves. Again, these are published figures, which I find plausible. They were surprising to me, but I was able to be convinced by that which I was reading. But also, it's nice to realize that that antiretroviral coverage in Africa is really surging. The last 13 to 15 years have seen heroic increases in coverage, and that means there are millions of people on therapy. And it's easy for us, easy for individuals who haven't been there, to ignore these really dramatic improvements in the care available. So again, it's perhaps a little subversive of me that I point out, if you think it's bad there, you have to first also look in your own backyard.
Then there's another question on page 29 of the original work, where there is a paragraph on disclosure and LTFU, long-term follow-up.
Yes.
The evidence supporting mandatory disclosure would be weak. That's a question mark with the question of Jean-Pierre van Geertruiden. So you mean that there is no evidence? Is there any research to your knowledge ongoing this topic? And what kind of research, study design you would think of, qualitative, quantitative, descriptive, interventional? So this is more a methodological question about the disclosure and the long-term follow-up.
I had expected a methodological question from Professor van Geertruiden. I think that that it's a very difficult question to study if you're looking at disclosure. So that's what we're talking about is, I don't know if I'm close enough to my mic to be heard by everybody. What we're talking about is individuals with HIV disclosing to those people around them, in particular, say, their sexual partners, or to others with whom they have a close social relation. And in the Gambia, we required people to disclose. It was require in quotation marks, but effectively people had to disclose to their sexual partner that they had HIV. They had to bring their sexual partners in for testing. And many people faced with this requirement dropped out of care. That was the last we saw of them because they were not ready to do that. There are settings where people have asserted that this disclosing has a real benefit. This comes back to the social support I said I wanted to touch on earlier. Social support is we often talk about social support as an adherence factor in sub-Saharan Africa when we mean financial support. So those studies that have shown social support, where you have to tell somebody you have HIV because you need their help, they're almost all situations where you need somebody's money in order to buy your drugs and to get your testing done. And so that's not social support, that's financial support, and the literature is full of people confusing these two terms, which is somewhat irritating. If we move aside all of those settings where people need their family members to, 10, 20, or 30 of their nearest family members to pitch in a little bit every month so that they can stay on their antiretrovirals. If we move out that financial question, are there studies that show that telling your sexual partner that you have HIV, that helps your adherence? I think that I can't remember the specific studies. I think I have read such studies, and if I didn't reference them in the paper, then I'm somewhat at a loss at this point too. But it's not convincing once you separate out the financial benefits.
Then there is a question on page 63, tables 2 and 3, on the HIV-2 papers.
Mm-hmm.
So did the treatment regimen have an impact on the survival? Did concomitant medication have an impact on survival? And male seems, after multivariate analysis, an independent predictor, question mark. Can you explain this? So there's a question, a sub-question on the impact of treatment on survival, on concomitant medication on survival, and on the aspect of sex.
I'm wondering if I can do something clever. But it may not be possible.
Yeah.
So these people got concomitant medications. They got the same preventive therapy, same management of opportunistic infections provided in the same setting, and they died in large numbers. So yes, the therapy, antiretroviral therapy specifically is the issue.
The other question was on concomitant medication, the impact of concomitant medication on survival of the two.
I think that's good. Here you can see it's not enough. Those people had their trimethoprim. You know, they still died in large numbers. So the antiretroviral therapy really is the cornerstone of HIV treatment. And that is not to say that I'm dismissive of trimethoprim sulfamethoxazole. Demonstrated mortality benefit, I gave it away like vitamins. But you can only manage opportunistic infections so long. If you don't interfere with the primary disease process, the people die.
And then the importance of male sex.
That is, I've puzzled over that one a little bit as a man, and wondered if we should see this as further evidence of our vulnerability. I think that there's a body of data, good body of data that shows that men tend to defer coming in for care. They present for care later, they have more advanced disease, and they adhere less well to their medications. We were able to show that it's not that they present late, that doesn't solve the whole problem. The cohort factors that out in the multiple regression. I suspect that it is something in the, and maybe this gets me into more trouble than the God question, but I expect that there's something in the risk-taking behavior of men that is a persistent risk to their health over time. And it probably is mediated through antiretroviral adherence.
And then there's a last question regarding page 74, but you may not have to look in the text. The question is, may it be possible to eradicate HIV too? Because it's less transmissible, there is slow evolution. However, treatment is less efficacious. So what's your idea about the eradication of HIV too?
Yes. I think HIV-2 can be eradicated. I think HIV-2 is being ushered out by HIV-1 at this point. And the best evidence we have for that comes from long-term studies in Cayo and Guinea-Bissau. Will we completely eradicate it? It's not a very efficient transmitter, but where people continue to take risks, we will continue to see sporadic transmission. I think we could effectively eradicate it.
This brings me to my questions. There has been for a while the idea that HIV-2 may protect against infection by HIV-1. Do you have any ideas on that? Do you have any observations on that?
That suggestion, that's really been well handled in a recent article by Tushon de Silva, who writes better than I do. I think that the initial case control observations in Senegal led to some enthusiasm for that idea, and I think it's been largely undermined by longitudinal work done in Guinea-Bissau and the Gambia. And it is sort of at a political, scientific level interesting that there's something of a Francophone-Anglophone divide. And I can recall reading a couple of years ago yet another suggestion that HIV-2 might protect against HIV-1. And I was impressed by the tenaciousness of the idea. There has been, and I'm not in a position to discuss it, but there has been some recent study that Dr. De Silva does mention in his paper, but the details of which I can't recall, which suggested that it was not crazy. So maybe that was an idea whose tenacity will eventually pay off as a minor player. But it's not, people get infected by multiple forms of HIV. Having HIV-1 doesn't give you protection against HIV-1.
HIV-2 is different.
Yeah, but...
No, the question is whether there are any solid epidemiological data regarding that. About a lower rate of infection by
epidemiological
HIV.
data, no, I don't think so. I think that there is one non-epidemiological paper that I can't well recall that sort of kept the flame alive. But I really I have to get back to you on that.
Or doubly infected people as compared to people who are only infected with HIV-1. Is there a difference in survival? Or has that not been...
It's HIV-1, it's HIV-1 that drives the disease. If we think back to the first slide where viremia is what drives the immune system down, for most people infected with both viruses, it's HIV-1 that comes in with a significant viremia, and in fact, within the body, it's outcompeting HIV-2. So you get a drop in